Welcome to the Explainer. Low back pain is probably one of the top 3 complaints we hear every single day behind the counter. So today, we're going to cut through the noise and get right to the evidence. We'll focus on the key counseling points and safety checks that really show your value in every single patient interaction. So picture this. A patient walks up, they're in pain, and they ask for your strongest stuff. We've all been there, right? But before you even think about reaching for a product, your most powerful tool is assessment. The quality of your recommendation really hinges on the quality of your questions. Let's break down exactly how to structure that conversation.
All right, so here's our game plan. We'll start with our role, then jump into screening for those serious red and yellow flags. We'll cover the evidence for acute pain, that first month, and then see how everything changes when we're talking about chronic pain. And finally, we'll tackle those really important cases, pregnancy and breastfeeding.
Okay, let's dive right in. Your role as a pharmacist really starts with understanding where the patient is on their pain journey. Is this a brand new thing, or is this something they've been dealing with for months on end?
And knowing the difference between these stages is absolutely critical because your goals are going to change dramatically. For acute pain, in that first month, it's all about rapid recovery. Then you hit that subacute phase where you're trying to keep a short-term problem from becoming a long-term one. But once it's chronic, we're talking over 12 weeks, the focus has to shift completely to restoring function.
Now this is where we really earn our stripes. A few key questions can help you quickly figure out who needs your advice versus who needs to see a doctor, like right now. This is where you go from just recommending a product to being a vital healthcare provider.
Okay, this is so important. These are the urgent red flags. If a patient over 50 mentions a history of cancer and they've been losing weight for no reason, or if they describe things like being unable to pee or numbness in the saddle area, that is not an OTC problem. That is an emergency referral. A yes to any of these means you tell them to see a doctor immediately, not to just try and NSI it for a few days.
So, beyond those immediate red flags, you also have to listen for what we call yellow flags. These are all about the patient's mindset, the things that predict long-term disability. So listen for phrases like, "I'll never get back to work," or if they seem super anxious or depressed about the pain. These are huge signs that they might need more support to avoid going down that chronic pain road.
All right, let's get to the most common thing you're going to see. A patient in their first month of pain and no red flags. So what does the evidence actually say we should do first? So check this out, because it might be the most important counseling point of all. The primary first-line recommendation is not a drug. It's non-pharmacologic. The best evidence we have says to encourage patients to stay active and get back to their normal activities as much as they can. Bed rest? It's not supported by the evidence. The medication is just there to help them stay active, not to let them lie on the couch.
Now, what about acetaminophen? It's got a fantastic safety profile, which is great. But it is so important to tell patients that the evidence for acute low back pain specifically shows it's not actually effective for reducing the pain intensity. So while it might be an option, managing their expectations is absolutely key.
Okay, let's talk NSAIDs. The evidence is clear. They work for that initial short-term relief, but your counseling here is everything. First, let them know there's no proof that one is better than another. Then, you've got to talk risks. Always cover the GI safety stuff, and definitely bring up cardiovascular risk, especially with diclofenac or high-dose ibuprofen. And by high dose, we mean 2,400 milligrams a day or more. The right choice is always going to be tailored to that patient's specific risks and, of course, what they can afford.
And then there are the muscle relaxants. Oh yeah, patients ask for these all the time. But the truth is, the evidence for any real benefit is contradictory at best. And what's not contradictory? The significant risk of side effects. It's a classic trade-off, and our job is to help the patient understand that.
So your counseling here has to be really direct. First things first, stress that these are for short-term use only. And here's a huge point. Adding a muscle relaxant to an NSAID doesn't actually improve pain, but it absolutely increases side effects. Make sure you warn them how common drowsiness and dizziness are. And of course, always caution them about mixing with alcohol or any other CNS depressant.
So what happens when that pain just sticks around? When it goes past 12 weeks and becomes chronic? Well, the whole strategy has to change. We have to pivot away from looking for a quick fix.
This is the crucial point right here. We have to help the patient shift their mindset. The conversation has to move away from how do we get rid of the pain completely to how do we improve your daily life and function despite the pain. It's about getting your life back, not just chasing a pain score of 0. And would you look at that? For chronic pain, the things that are most effective are all active and behavioral. We're talking about structured exercise, simple walking programs, cognitive behavioral therapy, and mindfulness. These are the things that empower the patient to take control of their own condition, which is way more sustainable than any pill.
And when we look at long-term medication, the evidence is, well, surprisingly weak. There's some support for NSAIDs, and duloxetine might be an option, especially for older folks. But for opioids and muscle relaxants, the evidence for using them long-term is either very limited or just plain lacking. That is such a critical message for us to get across.
All right, let's wrap up by tackling a super important area where our advice is absolutely vital: managing low back pain in patients who are pregnant or breastfeeding.
This step-by-step is your playbook. Always start with the non-drug options. If a medication is necessary, acetaminophen is your first choice. NSAIDs may be short-term, early on. But here's the non-negotiable part. Avoid them completely in the third trimester because of serious risks to the fetus. And opioids? They should be the absolute last resort.
And for a breastfeeding mother, your counseling has to be just as precise. Start with the safest bets. Acetaminophen and ibuprofen are your clear go-to choices. Muscle relaxants? Avoid them. Not enough safety data. Same goes for codeine. And if opioids are prescribed, you have to stress they should only be used for maybe 2 or 3 days, and you must counsel the mother on the signs of infant toxicity, like if the baby is excessively drowsy or having trouble breathing.
And this really drives it home. Over half of all pregnant women will experience back pain. This is not some niche issue. This is a daily conversation in your pharmacy. Your ability to give safe, evidence-based advice is absolutely essential here. It can prevent real harm while still helping someone get relief.
So ultimately, it all comes back to this. Whether the pain is acute, chronic, or in a special population, your most powerful tool is always education. This quote says it perfectly. When you shift the patient's focus from just passively taking pills to actively engaging in their own recovery, that is the key to better outcomes.
You know, our impact is huge, and it's multifaceted. We play a critical role in making sure medications are safe and in screening for those serious red flags. But look at this. Our biggest impact comes from empowering patients through education. It's about counseling them on the value of staying active and reframing how they think about their pain.
So, I'll leave you with this to think about. For the very next patient with back pain who comes to your counter, what's your first move going to be? Will you recommend a product, or will you start a conversation about staying active? Because reframing your approach like that can fundamentally change patient outcomes, and it solidifies your role as a vital, evidence-based member of the entire healthcare team.